Bismillahirrahmanirrahim. The next topic in vascular pathology is aortic dissection. So, aortic dissection occurs due to a breach in the aortic wall, and the swift flow of the blood separates the layers of the tunica media, hence creating a separate blood channel within the aortic wall. So, let's say this is a blood vessel. This is an endothelium with the vessel wall, and the high pressure blood flowing through this breach results in accumulation of the blood within the aortic wall. Risk factors for aortic dissection include, in most cases, age more than 40 to 60 years. Hypertension is a major risk factor of aortic dissection, since the increased blood pressure is catastrophic to aortic wall. Moreover, connective tissue disorders and atherosclerosis also result in compromise of blood vessel wall integrity, and tunica media infections such as syphilis can also result in aortic dissection. So, due to the presence of variable factors, there is a compromise in the integrity of aortic wall, and once there is a tear in the aortic wall, the high pressure blood dissects through the wall, creating a separate and a new blood-filled channel. This is a normal blood vessel with a streamlined blood flow and intact wall. In the next phase, what happens is that there is a formation of a tear in tunica intima, and the high pressure blood starts to move through this tear into the blood vessel wall, hence creating a blood-filled space within the blood vessel wall. This is known as dissection, or if it occurs in the aorta, it is known as aortic dissection. The gross examination of aortic dissection reveals a tear in the aortic intima. This tear could be either transverse or it could be oblique. There is a hematoma present inside the blood vessel wall, as you can see in this picture. This is tunica intima and this is tunica media, and this outermost layer is known as tunica adventitia. There is a blood-filled channel present between the layers of tunica media or the muscle layer. In certain cases, this blood-filled channel communicates with the lumen with a second tear in the vessel wall, hence creating an alternate channel for the flow of blood. In such cases, the aorta is known as double-barreled aorta, since it has two channels for the blood flow. In double-barreled aorta, the alternate channel created often gets endothelialized, forming a chronic dissection. The microscopic appearance often reveals degeneration of the tunica media, and the formation of dissection does not depend upon the severity of the degeneration. This could occur in certain trivial cases or even incomplete degeneration of the smooth muscle layers, forming a cystic lesion. Inflammation is typically absent. So, aortic aneurysm is broadly classified into type A and type B aneurysm. Type A aneurysm involves ascending aorta, and type B aneurysm involves the descending aorta. Type A is further subclassified into DeBakey type 1, in which the dissection segment involves the ascending aorta as well as the descending aorta. DeBakey type 2 involves only the ascending aorta before the origination of large vessels, such as carotid arteries. Type 3 DeBakey only involves the descending aorta right after the origination of large blood vessels. Type A aortic aneurysm, which involves the ascending aorta, is more dangerous and prone to rupturing and causing thoracic hemorrhage. Aortic dissection typically presents with the excruciating pain, and the patient describes the pain as a tearing pain, and it radiates to back between the scapula. The pain also gradually moves downwards with the progression of the dissection. The dissection could either progress in the retrograde direction towards the heart, or it could progress in the anterograde direction, which is away from the heart. The retrograde progression can result in disruption of the aortic valve, causing cardiac tamponade, aortic insufficiency, and myocardial infarction. The anterograde progression can compress carotid arteries, renal and mesenteric arteries, causing the ischemia of the end organ. Typically, there is an asymmetry of brachial, carotid, and femoral pulses. Chest X-ray shows broadening of the upper mediastinum and changes in the aortic knuckles. Echocardiography shows aortic regurgitation in case of involvement of the aortic valve. And the gold standard test for the detection of aortic dissection is MRI and CT angiography. Aortic dissection constitutes an emergency, and the medical management is with the blood pressure lowering drugs and rate limiting calcium channel blockers such as verapamil. The blood pressure lowering drugs and verapamil decrease the pressure and force on the aortic dissection, giving sufficient time for the clipping of the aortic dissection. So this brings us to the end of discussion about aortic dissection. If you have any questions, do let us know in the comment section. Thank you.